We'd like to thank all of you who've been on this journey with us for a long time, so long, but for a while. And for those of you who are here for the first time, we welcome you to this webinar series. We have some more amazing webinars coming up, so we'll give you a sneak peek of those. Ilan, if you could put the slides on the screen now for me, that'd be wonderful. Thank you. So we're just going to give you a very short introduction to Mind Medicine Australia, then I'll introduce Nikola. So tonight's session, of course, called Healing Addictions Through Psilocybin, MDMA, Ketamine and Ibogaine Assisted Therapies. Next slide. Just a reminder that we don't encourage or facilitate illegal use of psychedelics or plant medicines. Our focus is wholly clinical, and we're supported by the emerging science and legislative processes. We are recording these webinars, and we do share them with those who request them and on our YouTube channel. Next slide, thank you. So here we are, sitting in a terrible pandemic, but even worse than that, sitting in a tsunami of mental illness that we do not have the tools to treat. Before COVID, we had 1 in 5 Australians with a chronic mental health illness and an estimated 1 in 2 of us to suffer in mental illness in our lifetimes. 1 in 8 of us were on antidepressants, including 1 in 4 older Australians, and children as young as 5 being prescribed with psychiatric drugs. Due to the COVID pandemic, these statistics are being severely exacerbated. We're seeing a massive increase in suicides. And in Victoria alone, just in the last 6 weeks, there's been a 33% increase in self-harm by young people. This is truly tragic, and these figures can't do justice to the level of suffering and angst and heartache that is caused in the community. And realistically, Australia's mental health system is being crippled by the accelerating levels of mental illness in the absence of effective treatment options. Next slide, thank you. So we're a DGR1 registered charity, which my husband and I founded nearly 2 years ago to broaden the treatment paradigm available to medical practitioners and their patients, to establish safe, accessible and effective medicine-assisted psychotherapy in Australia for major mental illnesses. At the moment, our primary focus has been on medicinal psilocybin and medicinal MDMA because they're in breakthrough therapy status with the FDA. But tonight with Nikola, you'll be hearing about some other medicines as well. And certainly it's very important that we do make sure that other medicines become available, because some other medicines are particularly useful for specific conditions, and Nikola will no doubt touch on that. Our goal is that these therapies become an integral part of our mental health system, that they continue obviously with their incredibly high remission rates, at the moment up to 80% in 120 recent trials, leading to a substantial improvement in our mental health statistics. Our goal is that these medicines are accessible and affordable to all Australians in need, no matter where they're located. Next slide. So sadly, there's been no improvement in treatment outcomes over the past 50 years. In the case of depression, the 2 main forms of treatment are either antidepressants or psychotherapy. And between the combination of both those treatments, only 35% of sufferers experience actual remission. That is, they are cured from their illness. The remainder relapse. There's multiple side effects as a result of many of these medicines. And in the case of post-traumatic stress disorder, the remission rates are even lower. So more of the same approach is not going to solve the problem and is not going to manage the increasing rates of people who are experiencing mental illness, just generally, but then also in addition as a result of this crisis. Next slide. So our focus again is on psilocybin and MDMA, psilocybin particularly for depression, OCD and addiction, MDMA for post-traumatic stress disorder and also addiction. The remarkable thing about these medicines is that they only require 2 to 3 dose sessions in combination with psychotherapy for patients to go into remission. And this is against a lifetime of, taking medications, undergoing therapy. So, as I mentioned, this is wonderful because these medicines are actually curative as opposed to being palliative. They're considered very safe in a medically controlled environment and non-addictive. Both medicines have been granted breakthrough therapy designation, as I mentioned earlier, and that's to fast-track the approval process. And that therapy designation is only given to medicines which are considered vastly superior to existing medicines. Next slide. So our focus is on 4 key strategic pillars. The first of those is awareness and knowledge building, and this webinar is one of our awareness and knowledge events. We run regular education and events for the general public, for medical practitioners, for lawmakers, for a range of different organisations, political parties, whoever we can educate, so that MP by MP, doctor by doctor, person by person, we start to educate people about the science behind these medicines rather than focusing on the stigma or political machinations that have done a lot of harm to the research and use of these medicines. We've moved our major international medical summit to November 2021, but we will be still holding an introductory workshop in 2020. We're also interested in promoting and funding relevant research. For example, we're part funding the first Australian trial of psilocybin at St Vincent's Hospital in Melbourne at the moment. And we've commenced state and regional chapters around Australia and New Zealand. And we have, I think, about 30 of those at the moment. If you're not in a chapter, we urge you to join one if there's one in your area. If there's not, then you're more than welcome to start one of your own and reach out to us and we'll help you with all the processes and systems to do so. We've also commenced a professional development program, the Certificate in Psychedelic Assisted Therapies, which will commence in January, the first intake, and July, the second intake. This is for psychiatrists, psychologists, GPs, psychotherapists, mental health and addiction specialists, mental health nurses, social workers. I'm sure I'm forgetting things here, but pretty much any practitioner who wants to learn about these therapies and be one of the front runners in actually delivering these sorts of treatments. We've had well over 100 applications so far, and I think there's about 10 places left in the first intake and about maybe 25 or 30 places left in the second intake. So if you want to apply for this program and be one of the first practitioners in Australia, we strongly encourage you to do so. And it's important to note that these medicines are currently being made available through the Special Access Scheme. So psychiatrists and physicians are starting to get approvals through the TGA on a case-by-case basis for patients who are treatment resistant and who are at risk. So if you are a practitioner out there and you've got patients who fall into that category, feel free to approach us and we'll give you the forms so that you can apply to the TGA. In addition to that, we are in the process of setting up an Asia Pacific Centre for Emerging Mental Health Therapies for applied research and development, looking at the manufacturing and growth of these medicines in Australia, education and economic analysis. We're also looking at the preferred legal and ethical frameworks. And I'll come to that in one moment because today is a very exciting day for Mind Medicine Australia and for this movement in Australia. We also have a psychological support service which provides guidance to those of you who are using the medicines and need some more support. We have some wonderful psychologists and practitioners around Australia who provide support to those of you who need it. We're also looking at rolling out of clinics and a whole range of other exciting projects. Our focus is wholly clinical, as I mentioned before. So the next slide. So very excitingly today, the TGA announced that applications to reschedule psilocybin and MDMA have gone out for public comment. Public comment will be available for the next 4 weeks, and we really would like to encourage each of you to put in submissions. If it's about your lived experience, that's perfect. If you're a medical practitioner or allied health practitioner and you want to make sure that these medicines become available as another option to your patients, please put in a submission. We have excellent pro forma documents, and thank you to all of you sending your congratulations. Now we just have to get the rescheduling to happen, actually. So, we have pro formas, so to help you make this easier. But of course, in each of your submissions to the TGA, it's great if you put your personal situation as well and make your submission personal. But the submissions don't have to be long, and yeah, we would love you all to support this, what is a really historic moment. And can I say that if this happens, we will be the first, I think, is this right, Peter, the first Western nation to have rescheduled these medicines. And so that means that Australia actually has the chance to lead the world in this space, which is super exciting. Woohoo! So with that good news, I'm delighted to introduce Nikola. Nikola is, actually I'm going to let you, Nikola, just give your short précis to everyone, if you don't mind, because I think you'll do it better than what I can. But Nikola is on our advisory panel. He has vast experience working with addiction and trauma, and vast experience with these medicines. We're very honoured to have him on our advisory panel and presenting this webinar. So welcome, Nikola. Tell everyone just your very short little shtick, something maybe they don't know about you, or even if.
Well, good evening, everyone. Well, thank you for inviting me.
Hang on, we just need to unmute Nikola. Hang on. Ilan, could you unmute Nikola?
Can you hear me?
Yes, sorry.
Okay,
yes.
good. Yeah. So good evening, everyone. Thank you for inviting me and sharing this late hour with me. I'm an addiction medicine specialist. My career started over 30 years ago in mental health psychiatry. Then after moving in Australia, I worked in country areas, worked in remote Aboriginal communities and some very interesting places. And then after moving to Brisbane, I returned to mental health doing addiction medicine, became an addiction medicine specialist. And through personal experiences, I have got exposed to altered states of consciousness and experienced its healing power. So I'm not sure, can I start my presentation?
Please, please.
Okay.
You're a very modest person as well.
So yes, I would like to acknowledge first the spirit of this land. I think we need all the help we can get. Yeah. And also I would like to acknowledge all the participants in the audience who have lived the experience and who are struggling with addictions and mental health problems. Beautiful. I also would like to acknowledge a very good friend who recently passed away and was very influential on my where I'm at the moment, Tev Sparks, who was a great person in the holotropic movement. But also Stan Grove and Jeremy Halar, who was my mentor in addiction medicine training. So we are talking about how these psychedelic medicines can help in addiction training or in addiction treatment. Training, it helped me as well. I have to say, I was greatly influenced to return to mental health because I wanted to have these medicines and this type of medicine introduced into my practice. I would like to start with a personal experience back 12 years ago. I was lying on a mattress on the floor, breathing faster and deeper, listening to and immersing in heart-opening music. I was in a bliss, flying over landscapes, enjoying the beauty of nature. Suddenly, out of nowhere, an overwhelming darkness took over. With a gut-wrenching, painful feeling, a little boy appeared. He was lonely, helpless, and unsafe. I called out to get Tev, the male facilitator, to come and join my female sitter. That little boy is not safe, I told Tev. Oh, Nick, he replied as he laid down next to me on the floor. Tev and my female sitter cocooned me from both sides. Stay with it, sound it out, Tev added later. I followed up with a series of painful, deep, visceral roars pulsating through me. My whole body was twitching in waves. I brought up some of my stomach content, purging the darkness out of me. The feeling I experienced with my female sitter and Tev holding me between the two of them was that for the first time, both of my parents were holding the little boy to keep him safe together. I felt a new love and acceptance toward the little boy, released his pain, welcomed him back. Gradually, I relaxed into a mix of bliss and exhaustion as my supporters held me for long minutes. What can we learn from my experience? What would this scene look like to an observer who is not familiar with altered states of consciousness? It could be that I was convulsing, I was in a rage, I was in deep distress or in pain. Some would assume I was having a bad trip. In mainstream medicine, we want to immediately relieve pain and distress, concerned about the consequences. The client could even sue us for causing them distress. In this situation, the therapist allowed me and encouraged me to enhance my process in order to come to a resolution which was immensely healing. In analytic terms, I was addressing and processing pain from my subconscious. In shamanic terms, a part of my lost soul was retrieved. It was locked away, and after a long time, it was given the opportunity to rejoin my being towards wholeness or health. What do you think would have happened if the therapist decided to relieve my perceived distress? I believe it would have arrested my process, and that painful lockdown emotion would have been pushed back to remain stuck, reinforcing the hopelessness and the pain of that little boy. So, after my experience, we can think about whether it was a bad experience, a hard experience, or an amazing experience. So we can talk about bad emotions versus necessary emotions in psychedelic treatment. But what do we know about another person really? How can we interpret what clients are going through? And what is the truth? Depending on which direction we look at it and who we are, most of it we project onto the other person. So the reason why I'm bringing this up, because in psychedelic states, we have the inner experience coming up, and we have to trust what's happening. We have a healing ability, not just in our physical being, but also in our mental being. And that inner healing intelligence has to be trusted in a psychedelic state, or things can
Sorry,
go
Nikola.
the wrong way.
Sorry, are you able to please push the presentation mode?
Yes.
Thank you. If you could just go to the bottom left-hand corner of your machine. Yeah, thank you. Perfect.
Okay, thank you. So it leads us to thinking about the therapist's own experience. Does the therapist need an experience at all? And why? So we need to understand and navigate in that outer state of consciousness when the other person is experiencing it. If we are not familiar with that situation, with that space, how can we support another person to go through it? And when they go through some very difficult experiences, we need to know when to, and when, especially when not to interfere. As Carl Jung taught us very long time ago, the patient's treatment begins with the doctor. We are talking about very deep psychodynamic processes here, and we have a lot to learn from him. Another person who is relevant in this space is Matthew Fox, who made the comment that in this current New Age era, a lot of people think that all this beautiful, what some people call rainbows and dolphins, have to be around for us to have a meaningful and hopeful and helpful experience, and we ignoring the dark side, which can be immensely healing. So last 2 weeks ago, we had a wonderful presentation from Ellie and Alicia about trauma. I was a bit worried they put the mark so high. But I would like to add a little bit to it and think about who gets traumatized and what is actually trauma in this sense. I mean, we all get hurt at some point in our life, and what makes a hurtful experience into a traumatic experience? There is an example where in the Second World War, the children of London, a large number of them were evacuated to the country, and but some of them stayed back and celebrated Christmas in the tubes, the underground. Afterwards, there are studies clearly showing the kids who were out in the country, even though the bombing was not as hard, ended up in a much worse mental health state than the kids who stayed back with their parents and with a supportive environment. So that leads us to see what causes trauma really. It's not just the pain, it's how we can put it in context, how we will be supported during that experience, or not supported, or just abandoned. Another example is indigenous people. I actually work with these people. The territory still have a rite of passage ceremonies. Traditionally, some tribes have this type of marking where they cut themselves, put ash into the wound to create this keloid wound, and that gives them proud. But it all happens in the cultural context. It all happens in a tribal environment, in a very supportive environment where the pain doesn't actually cause trauma. So what is addiction? This is my absolute favorite description of addiction, that from Gabor Mate. Any behavior or substance that a person uses to relieve pain in the short term, but which leads to negative consequences in the long term. I mean, yes, we know a lot of other marks of addiction, you know, tolerance, people losing control. These are all the consequences. But what really happens is in addiction that people try to survive their pain with something that would alleviate it and let them survive and let them function and move forward. I see a lot of people in addiction, and I have not seen one person yet who had no trauma background. Sometimes they're not aware of it, but after a few sessions, it always comes out. In the mainstream, there is recognition where what we call an epiphany is necessary to move on with an addiction, and that epiphany is important to have realign the person, to rethink the meaning of their life, and psychedelic experience is very diverse to provide it, but it also takes time. So when we go to look at the different medicines, psilocybin, as we know, comes from over 200 different mushroom species. It was in fact synthesized by Albert Hofmann, who also synthesized LSD. He managed to synthesize it in 1959. Now, we probably have most of us seen this, but what does this diagram mean? In this diagram, we see the connections in the brain, which is examined with a functional MRI scan. And there was 15 volunteers who were examined before and after psilocybin. Now, psilocybin changed the connections tremendously. It actually generated connections in the brain that have never been, and remote connections that normally don't happen. So, as we already mentioned, psilocybin has a breakthrough therapy designation by the US Food and Drug Administration twice in 2018 and 19. There is also a very well publicized study from Johns Hopkins where 67% of people remained abstinent with one psilocybin treatment. In another study for alcohol use disorder, the drinking days is significantly reduced compared to placebo. So, and what was also found with psilocybin, especially in this alcohol study, that a mystical experience strongly correlated with the effect size. And finally, we are also very aware of the two studies that were used, that were done in end-of-life situations with significantly relieved anxiety in cancer patients. Now, MDMA. MDMA, we talk about a lot in the context of PTSD. And this is where most of the evidence lies. And as we discussed before, we have a very strong correlation between trauma and addictions. This person is Rick Doblin, who in 1986 established MAPS, Multidisciplinary Association of Psychedelic Studies. And his tenacity throughout these decades led to the situation where we are now. There's some co-workers, of course, but he was the driving force, where we are in phase 3 trials, and we are very close to having MDMA recognized for PTSD treatment in the mainstream. Now, MDMA, as we know, is a selective blocker of the fear response. So when we bring up in psychotherapy, when we bring up traumatic experiences, MDMA puts the patient in an ideal mental state to process that traumatic experience. Just before we go anywhere, I would like to go back to what the other mechanisms are, how psychedelic medicines can work in substance use disorders. And these are the recognized effects for many of these medicines. So we talked about the antidepressant effect of psilocybin, but it's well recognized that ketamine has a very strong antidepressant effect and works in addictions. Also, it can be affected by other psychedelic substances, ayahuasca, LSD, and others. New connectivity in the brain I already showed with that fMRI diagram. Healing the effects of trauma, I talked about a lot. And the next one, enhancing neuroplasticity, which means creating new connections in the brain, but also regenerating the brain, creating gene expression for substances that are responsible to regenerate the brain. There's also another way that's recognized is neuroinflammation. It's another branch of research that's currently happening, not just in substance use disorders, but in mental health. Some psychedelic substances like Ibogaine has direct effects on opioid receptors, which puts it in a place for those opioid substance use disorders. And what I already also mentioned is the mystical experience that seems to be essential to create a breakthrough in treatment with substance use disorders as well. Now, we need to talk about, I was asked to talk about ketamine, but I need to talk about ketamine a little bit in the general terms, because there's a lot of misinformation and prejudice with ketamine. It was synthesized in 1962, and it was used in the Vietnam War, gaining a very good reputation among soldiers because it was very safe and gave really good anesthesia without dropping blood pressure and putting the injured soldiers into a dangerous situation. There's a recent surge in ketamine research, especially in the US. Lots of ketamine clinics sprouting up, over 50 clinics using ketamine-assisted psychotherapy, and hundreds of different ones using ketamine infusions, especially for depression. It's also a drug that's on the essential drug or essential medicines list of the WHO because of its safety profile. Now, a lot of times it's described as the horse tranquilizer, and it is a horse tranquilizer exactly because it's safe. Can you imagine put a horse down in an anesthetic state? It requires a lot of equipment. So if you give ketamine, you don't need to use an anesthetic machine for that horse. And you can do an operation. Not sure if you remember this event when the kids got stuck in the cave in Thailand, and it was ketamine that was used to get them through the water, because again, it doesn't knock out respiration, so you could safely extract them from there. It's a famous study for ketamine that shows how ketamine induces synaptogenesis. It increases the nerve regeneration in the brain. So it also potentiates the BDNF expression and decreases neuroinflammation. So there are some very well publicized studies for ketamine use or ketamine treatment in substance use disorders. Krupitsky, who used it for once in alcohol use disorder with very good results. 65% abstinence after 1 year receiving ketamine assisted psychotherapy, which is unheard of. You need to know that mainstream alcohol treatment normally achieves around 20% maximum in a 1 year follow-up. So it's significantly higher. Also used in opioid addiction and similarly very good results. Now, ketamine also has been approved by the FDA as a treatment for depression, using esketamine, which is a version of ketamine. It's one of the spatial versions, 50% right ketamine, 50% left ketamine, and they just divided it so they could put a patent on it, and they made it very expensive. But it is now approved for depression treatment in the US by the FDA. So we've got our own clinical data in Brisbane, where we did our own statistics. There's a couple of psychiatrists who prescribe low-dose ketamine in treatment-resistant depression, and there are some very good results for staying out of hospital with ketamine treatment. Now, this is not, it is just the pharmaceutical use of ketamine, not the psychedelic use of ketamine. And that leads me to the 3 paradigms of ketamine treatment, and that applies to all other psychedelic medicines. A lot of people are not quite sure about it. So it depends on the dose and individual sensitivity. There are different ways of using psychedelic medicine. Can use it in a small dose where we do not aim for any mind-altering effects, which is we call microdosing. It's very popular at the moment. A lot of people do it with LSD, with psilocybin mushrooms, and I've seen really good results with some of the patients I come across. The second one is the psychological or empathogenic paradigm, which is the mini dosing, in other words. And the third one is the psychedelic paradigm. So in the first paradigm, the biochemical or pharmaceutical paradigm, we basically prescribe the medicine, or people can get it in other sources, and take it on a regular basis. Normally not daily. It's every second day or maybe twice a week. It's more efficient, and it is explained by the biochemical or physiological ways. It also puts the patient in a passive position, because we just prescribe it. They go home, they take it like they take their antidepressants, and whether it works or not, time will tell. So this is also a microdosing way when we give ketamine in an infusion. It's a low dose infusion in very popular in the US. It only happens in Australia in some research, very limited scope at the moment. So the psychological paradigm, the empatogenic experience with ketamine, it acts as a lubricant in the psychotherapeutic process. It can also alleviate the fear response, very similarly to MDMA assisted psychotherapy, creating a state of comfort, relaxation, reduces the ego defenses, and creates an empathy to the self. It is very useful. It's a bit harder to titrate than MDMA. And the environment would look like a more friendly, supportive container, which is like a basic psychedelic psychotherapy. And the last one, the psychedelic or shamanic paradigm. So in a higher dose, and it's usually with intramuscular administration of ketamine, we can achieve a full psychedelic effect. It is slightly different to the classic psychedelic experiences in that it's somewhat darker. It often causes disembodiment, so losing some of our parts of our body, can experience and look at our death, and also very vivid mystical experiences. It causes partial paralysis, being an anesthetic drug, which can scare some people if they're not prepared for it. But the amazing thing about ketamine, it is actually reasonably short acting. So you can have a session of 1 to 1.5 hours, as opposed to other psychedelics. Psilocybin is 4 to 5 hours, LSD 7 to 8 hours. So it's more, it gives itself more to the office procedure. And the last one I would like to talk about is Ibogaine. Ibogaine comes from, it's one of the main alkaloid in a Western African shrub, Iboga, which mainly in the root it can be extracted from. But you can also extract it from other plants, but traditionally this is where it comes from. This is what it looks like in nature. Now, the story of Howard Lotsof. Howard Lotsof was a 19-year-old heroin user, dependent on opioids, in 1962, when by a friend he was given Ibogaine. He took quite a large dose, and this is his experience. 33 hours later, I only thought to myself, I'm exhausted, I'm going to sleep for a week, and I'm never going to take this drug again. I got dressed, walked out of the house, and that's when I realized I was not in narcotic withdrawal. And I looked at this large tree in front of me, then I looked at the clouds in the sky and realized that for the first time in my life, I was not frightened. I perceived that in my entire life, I had been full of fear. So this experience led him to dedicate his life to Ibogaine and trying to get Ibogaine into mainstream addiction treatment until his death, 2010. there is an Ibogaine movement, which unfortunately is mainly underground, although there are a few countries where it can be legally administered. Now, talking about Ibogaine, when you hear about people's experiences, being a natural, originally natural substance, iboga, they call it the father of psychedelics, while ayahuasca is the mother of psychedelics, where the mother is challenging, but it's also forgiving. It's also much lighter, more fun, while Ibogaine is heavy. It's not forgiving. It's once you're there, you have to be there. Iboga has been used by traditional people, tribes of Western Africa, and there is a whole church based on Ibogaine on use the Bwiti. They use it for all their ceremonies. Now, again, the psychological effects of Ibogaine slightly different to the classical psychedelics. It's described an onaerogen producing waking dreams, like watching a movie where you can watch your life story with your personal content without the emotional attachment. It can give you a very deep state of contemplation and self-reflection. I'm not sure how many of you watched the movie Dosed. It was an amazing documentary about Ibogaine treatment. I think it was very realistic. It showed the pitfalls and the difficulties of Ibogaine therapy, and also you can see why it's really important that someone's very well prepared for this treatment. An Ibogaine treatment is not something that can be done in an office. It takes about 3 to 5 days to go through it, and there are different stages of the effect. It affects your physical body significantly. It definitely causes purging. It definitely affects the heart. It can cause, in certain people who have predisposing conditions, even a cardiac arrest. So it cannot be taken lightly. So some people within that Ibogaine process, they regress and go through developmental stages from early infant, toddler, child, adolescent use, and they act like that. So it can be falsely interpreted as cognitive impairment if you're not familiar with it. It can also bring up suppressed traumatic experiences, like we mentioned with other psychedelic states. So it affects the body. It causes ataxia. It takes sometimes 2 or 3 days for people to get out of bed because they're unable to actually stand up and walk and need to be supported. It causes tremor, but not seizures. Mentioned nausea, vomiting. It really increases your sensitivity to light and noises. In fact, it was used traditionally for hunting, where these tribal people would go hunting at night and would actually see more than without it. It has an effect which can cause insomnia and irregular heart rate. So in summary, it's definitely not fun. And what's special about Ibogaine, it mitigates the opioid withdrawals. So when you are in withdrawal, take Ibogaine, after the effect sets in, your withdrawal goes away. But it also potentiates the effect of opioids. So if someone has still opioid in their system, it can end up with an overdose when using Ibogaine. So it's very important that you need to be in a withdrawal state before taking Ibogaine. And this tolerance, this loss of tolerance is actually permanent well after the treatment. Now, there are Ibogaine treatment centers in Canada, in Mexico, and in Portugal, where it's legally administered. Clear Sky in Mexico, which is probably the center that treated the most clients. They're up to about 4,000 treatments, and they have not had one death because they properly screen their clients and monitor them. So what is Ibogaine treatment and what is it not? So it's definitely not a magic bullet. It will not eliminate all aspects of an addiction. It will interrupt your addiction, but if you go back to your old life and setting, it will not change that predisposing environment, and you might plunge back into it. So it is safe and dangerous. It's safe in the right setting and dangerous in the wrong hands. So in conclusion, I would like to speak a little bit about just psychedelic assisted therapies. I think these 4 essential steps cannot be bypassed if we want to do it safely. The first one is patient selection, and we need to decide and we need to come to a conclusion which paradigm is best suited to that particular client. Not everyone is suited for psychedelic psychotherapy. You might need to do other psychotherapy and render that particular person ready for a psychedelic session. And you just start with microdosing, for instance, and maybe later on, when things get a bit more settled and stable, less anxiety, less fear, more familiarity, then you can go into a psychedelic session. The preparation, extremely important. I have seen quite a few clients who were given, for instance, ketamine. As I said, sensitivity is different. So some people can have a psychedelic experience from a very low dose. And if they're unprepared, they panic. They can have a really bad experience. So need to tell them what might happen, and you will be there for them and support them. The third one will be the medicine session. Most of us know about setting and choice of medicine, but just to rehash, set means that the particular client is ready, is willing, and is informed about that psychedelic therapy that will undergo. And the setting is what we provide, a safe container, a familiarity and support during the session. A choice of medicine, I get a lot of questions about that. What suits what condition? It's not an easy question. As we know, certain medicines are better suited for PTSD, like MDMA, but the availability is limited too. So whatever is available, whatever the readiness is, will dictate the choice of medicine and the dose. And finally, the integration. Without integration of the experience, we might end up with something that is definitely unwanted. There was some talk about psychedelic flashback or hallucinogenic perpetual disorder, which means that psychedelic experiences are not properly integrated, and they keep coming back, and they're calling for integration, and they're affecting people, and can be interpreted as psychosis. So again, problems can happen and occur when we bypass some of these stages. And thank you very much. This is the end of my my presentation with this wonderful sentence up there from Randy Hankin. It's a doorway that you can walk through. On the other side, you are clean. It will not stop you from walking back. You have to keep walking away. Thank you very much.
Thank you, Nikola. Thank you so much, Nikola. You are so learned in this space, and we're very lucky to have you working with us, and we appreciate this talk very much. What we're going to do now is we're going to open the chat up again, and we're going to rattle through some questions. There's an initial question I saw just at the start, which I'm going to ask you to begin with, Nikola. I don't have it in front of me right now, but it was along the lines of, you know, you were talking a lot about your holotropic breathwork experience. And the question is around why employ the psychedelic experience, as with psychedelic medicines, when breathwork can achieve the same. Now, I would argue that it couldn't, but you're the expert here, so perhaps you could give that, you could answer that question first. Thank you.
Some people at breathwork will not achieve the same state as psychedelics would achieve for them. Psychedelics would definitely you take the altered state further. There is a limit with holotropic breathwork how far you can go. There is a lot more control. So people not ready for a psychedelic experience, they definitely much better suited to start with holotropic breathwork. Holotropic breathwork again is something that is not easily available when medicines can be much easier available than breathwork sessions on a regular basis. So I strongly encourage people to try both if they need to, and see where they get with it. I think in my journey, both of them were essential.
Okay, thank you for that. Another question too is, how do you decide between when you use, for example, psilocybin or ketamine or Ibogaine? So as the practitioner, or MDMA, how do you decide, and do you ever combine MDMA with any of the others as well?
I would definitely not combine them.
Yeah.
I know there are a lot of underground therapists who probably have much more experience using some of these drugs and in combination. But I think in the medical setting, we should not combine two medicines. I think there are so many questions and uncertainties just using one medicine that putting in another one in, I think would just complicate things in a way that we don't want to have it. The choice of medicine is, I think, depends on a lot of factors. It depends on the therapist. It depends on what you're familiar with. It depends on what you're confident with. As I already mentioned, I think it's very important that the therapist is familiar with what the therapist is using, to be confident, to be supportive, and and giving that energy and that safety to the client in that setting.
Thank you. So Nikola, what we're going to do, because we're getting so many questions now, is I'm going to do short questions and you're going to give me short answers. Okay. Otherwise we won't be able to answer all the questions, and we'll try to answer as many as we can. Okay, so there's a couple that we will answer as well. So a question here: if the TGA receives a large amount of public support for these medicines, what will the impact be? So the impact will be that hopefully they'll be rescheduled to Schedule 8. Nikola, you might like to comment on what that would mean for you as a practitioner, please.
I would be able to prescribe these medicines in a controlled setting. As simple as that. And
yeah. So that's a big deal, right?
And get more experience, you know. I mean, it's we all have to learn. I mean, there's no end to it.
Yeah. Okay, thank you for that. There's a question here. What is the experience acceptance of Aboriginal Australians in psychedelic treatments? Is there a traditional experience of this? Nikola, being that you're not from Australia, do you have any comment to make on that? Or
I worked with Aboriginals quite
excellent.
a long time in the Northern Territory, and they were
Yeah.
traditional Aboriginal people. Now I have to say, they largely lost the tradition of using mind-altering substances, or at least I'd never heard about it. I mean, I worked very closely with them, so I really assume I would have. Well, I saw and results of ceremonies as well, but there was no traditional medicine involved anymore.
Thank you for that. I think now, actually, there's quite a lot of talk, isn't there, about the acacia bush. Is that right, Nikola?
Yeah. Acacia is good, yeah.
Okay, we'll go out into the centre of Australia and pick some acacia then.
I mean, acacia basically is a plant that has DMT. So it can be used the same way as ayahuasca is. You have to combine it with another substance, which is an MAO inhibitor. The enzyme that breaks DMT down needs to be inhibited to have a sustained effect. Otherwise, it will be only a few minutes.
Okay. A question here, which is about, will the rescheduling of these medicines, when will this occur? So basically, we should get an outcome by next June. So it's an 11-month process. But now this next 4 weeks is just really critical, and I urge all of you and to reach out to your colleagues and networks to put in submissions. And Ilan, in the thank you note to this webinar, could you make a note that you will provide a link for the rescheduling papers and so on? Thank you. So we're not looking at many years. There's a question here from Eternity about how many years. No, we're not looking at an eternity. Sorry, Eternity is the name of the person who asked the question. We're looking, by the way, also at the fact that MDMA is expected to be prescribable within 18 months and psilocybin soon after that. But of course, we also have the SASB, and then we have this rescheduling as well. So,
can I just say one more thing?
Yes, please.
I also would like to mention that it's not much mentioned with mind medicine, that I think one of the major achievements that mind medicine had in this country is bringing people up and giving them a bit of a platform and confidence to talk about what they were hiding for many years, and talk to each other and create, a community. I think it's amazing what you guys are doing. Thank you.
Oh, thank you. Thank you. We think you're amazing too. There's a question here from Anne. Oh, Anne Schlag from Drug Science in the UK. We have people from all over the world on this webinar tonight. Thank you, Anne. Could you please elaborate on the differences, Nikola, between paradigm 2 and 3 you mentioned? Was that only in relation to ketamine? No,
that's all psychedelic substances. It can be applied to all psychedelic substances. I mean, I know not all of them, but we know that there is different use of these medicines. Like, when microdosing is pretty common now with LSD and psilocybin or mushroom powder. People who go to events, festivals, they use a bit more. They want a loosened mindset, to enjoy the environment, to immerse into the community. That's what I would call more the empathogenic, the second paradigm use. This recreational level of use, and we also see in these festivals that someone might take a little bit too much, and then they go into the third paradigm, which is the psychedelic paradigm, and they end up in the support tent, which I had the opportunity to help in some of these places. So yes, it's basically almost all substances give themselves to use it in these different levels, but a lot depends on the setting as well. Like I had people when we went and did holotropic workshops, who, when we were just first sitting in a circle, just discussing what's going to happen, they fell off the chair and went into a process, because they were so eager to have that started, that healing, that so wanted to come up. Sometimes you give a psychedelic to a person and their defenses are so hard that they do not allow to put them into process. So it depends on a lot of different factors. The main thing is we support the people who try to heal and help them to get into this process.
Thank you so much. So now there's really a lot of questions. So we're going to go as fast as we can, even faster. Are there any recommended support readings for the integration process for a client when the integration is difficult? Is there any books or any other papers you recommend? You don't have to tell us now, but we could
for
provide
the therapist or for the client. I mean, that's a big difference.
I think it says for a client when integration is difficult. So look, one of the things I'd say about that is I wouldn't
recommend self-integration. I'm sorry.
No, and that's why we've set up the psych support service program. So if you're having trouble integrating, please reach out to the psych support services, and we will be able to direct you to a practitioner.
Yeah, someone who has the credentials of doing that work.
Next thing, are these therapies available now? I'll answer that question. So again, the therapies, psilocybin and MDMA, are available now through the SASB on a case-by-case basis for specific treatment-resistant patients. So you also need a psychiatrist or specialist like Nikola, who's a prescribing physician. Nikola is in a position to make applications to the TGA, I believe, and but don't all rush him at once. Is that right, Nikola?
Well, yes, I could, but it also depends on a lot of my professional settings.
Okay. Hi, Nikola. Have you had any experience with clients following up with a 12-step model as a form of integration after psychedelic sessions for addiction?
Oh, well, the 12-step model works with or without psychedelics in a lot of people. I have to say that Bill Wilson, who established Alcoholics Anonymous and worked out the 12-step program himself, had a lot of LSD experience before it became illegal in the US. So he could not continue and he could not recommend it any longer. The 12-step sets people up on a spiritual journey. I think it's extremely important. It puts people into a setting where they can share their experiences, which is also important to be part of a community, which is very important.
Okay, I'm going to have to ask you the next question. I've got to do speed dating thing with you. Okay, next question. Someone here is asking about addictions like sex and food. How do you think you can treat addictions like sex and food addiction with plant medicine therapy? Is that possible?
Exactly the same as any other substances.
Thank you. a question here, where do you see naturopaths in relation to being practitioners involved with these types of treatments? I mean, I think that naturopaths who have a lot of experience in therapeutic environments and have the right qualifications, we'd certainly welcome applications from those with the right applications to meet these certificate requirements. Is there a specific email or website URL to make a submission to the TGA from the public? Ilan, could you please put that on the chat screen now as well? Thank you. Hang on. Hang on a minute. Okay. How many people have utilised the special access scheme yet in Australia? Yeah, there's been about probably 10 approvals so far. This is relatively new. And we need to obviously educate many more practitioners so they understand the benefits of these medicines. So what I find quite surprising is how many psychologists and GPs and others who actually have never even heard of these medicines. So each of us, you know, can take really strong actions just by informing and educating others about these medicines. Let's just see, there's so many here. The question here, there's coming into therapy as an educated patient, I find to get a negative reaction to asking or mentioning any of these therapies. It's seen as a grab for drugs, not legitimate treatments. So the important thing there again is to educate medical practitioners about the use of these medicines in medically controlled environments, to reiterate the point that, you know, no one is looking to do these as a party drug or for recreational purposes. All of us really need to focus on that. Just moving on to the next one. Okay. Lots of great comments, Nikola. Nikola, is there any bad side effects of ketamine or Ibogaine that you quickly would like to mention?
Oh, absolutely. If it's given to the wrong patient at the wrong time by the wrong person, it's definitely a big side effect.
Okay.
Ketamine physically can also cause a raise in blood pressure. So someone who already has a high blood pressure, already has a condition where their heart is weak, or someone has an impaired liver function, then we don't know how it's going to be metabolized, but it again applies to many other psychedelics.
Mm-hmm.
So it should not, people need to be screened before ketamine, but it's still very safe. Ibogaine, on the other hand, can be a little bit more dangerous. Ibogaine has a propensity of putting people into a cardiac rhythm if it's given to the wrong patient, where they can have a cardiac arrest.
So don't go out and do this at home anyway.
Definitely not for home use, that's for sure. So again, it needs to be really given in a medical facility, Ibogaine, in a monitored setting.
So there's just one more question I'm going to ask before we show you a couple of more exciting things before we head off. This one, Nikola, how would you approach helping someone overcoming resistance to surrendering to the psychedelic state in the process of therapy? A significant aspect of addiction involves maintaining control over painful emotions until they become too overwhelming to manage.
Well, it's
good question, hey?
I mean, whoever is psychodynamically trained, we talk a lot about resistance. And Jung said that resistance really needs to be respected. So I would recommend just work around the resistance. Address the resistance. Address why, what's the function of that resistance is. Why is it happening?
Yeah.
And quite often it can be overcome by doing that. but again, put everything right for the actual session will make it much easier.
Thank you. Another question here. Yes, nurse practitioners can apply as well as GPs and all other qualified practitioners. So please don't miss out on the opportunity to be part of the first couple of intakes. Ilan, just put on those last couple of slides just very quickly. Thank you. So this is Tim Ferriss's statement about the importance of this time window in really investing to create impact in terms of healing people with mental illness. And the next slide, please, Ilan. So these are the ways that you can help. Start conversations, share this info, volunteer, join our chapters, read our educational content and learn section on the internet, talk to your doctors and medical professionals, talk to your local MPs as we've discussed. Every person you can talk to and inform and educate will make a difference. Peter and I, philanthropists, we do this entirely because we want to help people who are suffering, and our focus is entirely non-profit based. So we give our, philanthropically based, we give our time, we give our money. We can't do this alone. We have probably 150 to 200 small to medium to large donors. And we encourage you, even if you can't give a lot, to give regularly. It all adds up and makes an enormous difference. And to achieve the outcomes that we need to achieve to make these medicines part of the medical system does take a lot of investment and a lot of work. Ilan, did you mean to circle that? That's very bizarre. Next slide, please. Can you go to the next slide? Oh, did you? We've just lost our slides. They'll be coming back in 1 second. We're nearly there. Just popping our slides back on. It's bizarre. I don't know. I think phantoms must get into the feed sometimes. Next slide, Ilan. No, well, we need to show these slides. Ilan, could you put the slides on again? Thank you. So this is about our certificate in psychedelic assisted therapies. There's a list of some of the types of people that qualify for it there. Ilan, if you could just go back to the how to help slide just for one more moment, thank you. That'd be great. Definitely follow us on local social media and attend our events. And of course, our summit has been moved to 2021, but the introductory workshop is still taking place in November. Next slide, thank you. The certificate, and please do put in your applications. I think we've spoken enough about that. And the next slide. So this is the summit. We'll move on. This is the dates for 2021. Oh, just go back one more time. Yeah, just block those dates into your calendar. We hope to see you all as part of this, and look forward to seeing you very soon in person, hopefully at other events well before then. Next slide, thank you. This is again reminding you that the psilocybin and MDMA rescheduling submissions are now open. And the next slide, thank you, Ilan. So these are the upcoming webinars. So this one, the next one actually is really about the special access scheme, and that will be on September the 9th, and it will be with Dr. Elgris Gaitis and Peter Hunt and myself and others talking about the special access scheme and how we can work together to ensure that these medicines become available to people who desperately need them now. The next one on September the 23rd, Psychedelic Therapy is a Rite of Passage with Dr. Anna Rubinstein, who's a leader in rites of passage, from mental illness to mental health. In October, we're going to have a stack of webinars. We'll be announcing a number of those soon. Some of them will be with international guests. A very interesting one there on consciousness and religion. We'll also be having part 2 of the conversation between a psychologist and psychiatrist on trauma and addiction, which happened a couple of weeks ago, which a number of you requested. We'll also be looking at cross-cultural taboos and nuances. Next slide. That's it. Okay, so we'll go back to the gallery. Just take those slides off. Thank you, Ilan. Thank you, and thank you to everyone. So thank you all. Thank you, Nikola. We hope to see you at the next one. And if you could bring 2 or more people to each webinar that you come to, then we will grow and grow, and we'll educate and inform more and more people. And then these medicines will be able to become available sooner and more easily to those who need them.